little bit about our larynx anatomy, right? I told you that everybody should be able to identify all these structures in this class. Have you read it? Can you do it? So this is a cut section, right? Which cut? Coronal cut. How do you know it's coronal cut? Coronal cut means what? Like this, crown like this cut, okay? This is a coronal cut section, cadaveric specimen, right? So you all know, I think you have already had a class on larynx by another faculty. So, yes or no? Okay. So larynx anatomy very easy, okay? We have two pipes in our neck. One is windpipe, one is foot pipe. Windpipe is anterior location. So that conduit to the lower respiratory tract from your nose and mouth to your trachea, this conduit is basically, this intermediary conduit is larynx. What is the main function of larynx? Anybody? Sound production. You mean vocalization? Passage of airway? No. The primary function of larynx is protection of lower airway. That is the primitive most function. With time, nature may have thought that where should I place this something extraordinary, we call it vocalization or sound production, okay? So we can produce sound with our esophagus as well, with our palate, with our tongue, we can produce some sound, right? But fine tuning of the sound is possible because of this unique structure of vocal cord, okay? And that vocal cord closes during what? While we are trying to swallow the food, okay? And as it's closed, the lower airway is protected from aspiration. Imagine a situation when these vocal cords are not properly acting because of some nerve palsy or something, right? So what will happen? The patient will aspirate. Okay. So prevention of aspiration is the primary function of larynx. Other functions are voice production, as I am giving you lectures, and passage of airway as well, right? Okay. So this is vocal cord. What is the lining of vocal cord? Histology? What? Stratified? Squamous? Non-keratinized? Okay. Epithelium. Okay. So this is vocal cord, right? And vocal cords have some muscles, and those muscles have some nerve supply, right? So can anybody tell me what is the nerve supply of larynx in a nutshell? Supplies what? Think about the vocal cord and above the vocal cord separately, okay? Just remember one muscle, the name of one muscle, that is cricothyroid. It's a very unique muscle. Cricothyroid is being supplied by? No. Cricothyroid is the only tensor. Cricothyroid is being supplied by external branch of superior laryngeal nerve. Okay. So this is the exception. And all other muscles of the vocal cords are being supplied by recurrent laryngeal nerve. Right? Okay. So one of the important muscle that is abductor of the vocal cord is posterior cricoarytenoid. Because of this, that is safety muscle. Okay, it helps in abduction. All other muscles are adductors. Okay, and tensor is that exception, cricothyroid. Okay, so very easy. All muscles of vocal cords are supplied by recurrent laryngeal except cricothyroid. Okay, which is being supplied by And what does the internal branch do? What is this function? The sensory function. Sensory function is also important, right? Okay. So this is vocal cord. This is epiglottis, right? Epiglottis is a cartilage. It's a cartilage. Paired or unpaired? Unpaired, only one epiglottis, leaf-like structure. Okay, that is the first thing we see when we do laryngoscopy. First thing, tip of the epiglottis. After that, we proceed for the vocal cord. So epiglottis, it does not ossify any time in your life. Thyroid cartilage ossifies, cricoid also ossifies, but epiglottis does not ossify. Okay, it is elastic cartilage. Okay, okay. So this is epiglottis. This is vocal cord, and above that there is it's a fold. It's not a typical vocal cord like structure, but we call it false vocal cord, right? In between there is a space, right? This is vestibule, okay? And the extension of vestibule laterally is the ventricle. We call it laryngeal ventricle, okay? This is the cut section of cricoid cartilage. This is hyoid bone. This is the hyoid bone, right? In between hyoid and thyroid cartilage, there is a membrane. That is thyroid membrane. This is the thyroid cartilage. Thyroid cartilage have many parts, and these are the tracheal rings, right? So this is a very simple structure. But the internal part is little bit complex. Sorry, little bit complex. And it has very fine tuning of different kinds of function. There is a space, a potential space where malignancy can hide and spread and hide. We call it pre-epiglottic space or space of Boyer. Okay, it's known as space of Boyer as well. This picture you will be asked to draw in your exam. Okay, this is the with laryngeal mirror or with endoscopy, whatever it is, this is the view. This is the view we can have with our direct or indirect laryngoscopy. This is the epiglottis. This is the vocal cord, right? White structure. Just above the vocal cord, there is a fold, false vocal cord. These are the cartilages. One is arytenoid cartilage, and there are other two rudimentary cartilages. What are the names? Cuneiform and corniculate. Okay. Just here is the pyriform fossa, and this space is known as post-cricoid space because there is this just behind this interarytenoid muscle. This space is known as post-cricoid space. Okay. And this is in nutshell, what are the abductors? There is only one abductor, posterior cricoarytenoid. If it gets paralyzed, the patient will have what? Abduction will not be there. So, what is the vocal cord position? What will be the vocal cord position? The patient cannot abduct, right? Cannot open it up. So, vocal cord will be in adducted position, right? It will not move. It will not abduct. Tensor is cricothyroid, little bit from the vocalis as well. Okay. This is the vocal cord, layer by layer. First is squamous epithelium, then basement membrane. They are superficial lamina propria. MCQ comes. This space is known as Rinky space. Okay. Sometimes edema, fluids get accumulated and there is a edema. We call it Rinky's edema in smokers. Okay. So these are the function, and this is the nerve supply. So recurrent and superior laryngeal, both nerves are from vagus. Why it is recurrent? Because it comes from the vagus, goes down, and on the left side it recur back. It comes back. Somehow the nerve has forgotten that I need to supply something. So it comes back. Okay. Left side it is the brachiocephalic trunk, right side it is the subclavian artery. So left recurrent laryngeal nerve is lengthy, more lengthy, okay, because the arch is It arches back from the brachiocephalic trunk. So, in thyroid surgery, this left-sided recurrent laryngeal nerve gets more injured, okay, because of its course. So, hypopharynx is an area, it has been subdivided in three parts: posterior pharyngeal wall, pyriform fossa, post-cricoid space, okay. Exact anatomy, you read it out. Now, coming into few conditions of the vocal cord. That's the main purpose of this class, okay, to give you an idea. This is Rinke's edema. What is the edema? Which space? Superficial lamina propria, right? That space is known as Rinke's space, okay, in smokers. This is one polyp, right? This is vocal cord polyp. How will you treat it? Will you cut it out? The surgery is known as microlaryngeal surgery. We introduce a laryngoscope, we see it with a microscope, we zoom it out, and we do exactly where the polyp is there, we will cut it out, okay, without injuring the vocal ligament, the deeper structures, okay. That is the main purpose. What is this? Laryngocele. What is laryngocele? পড়া হয়নি? Basically, it's a potential space, extension of the lateral the laryngeal ventricle, okay. So, there is some changes, some fluid build up or anything. If it happens, we call it laryngocele, okay, like mucocele. This is vocal process granuloma. Where does it happen? During intubation, okay. Suppose you are an intern, the anesthesiologist or the ENT surgeon gives you the opportunity to intubate a patient, and without having much thought, you are saying, I am able to see everything, okay, and you are trying and trying and trying, and you injured those things, okay. So, this granuloma can develop, right? This is vocal nodule, also known as singer's nodule or teacher's nodule or politician's nodule or whatever you say, you call it. So, this is the typical location, anterior 1/3 and posterior 2/3, there is this nodule formation, okay, because this area is mostly vibrate during high pitch of voice, right? Okay. This is laryngomalacia in neonates. Sometimes the parents come to you with some stridor in a neonate or an infant, and this is typically the laryngomalacia, okay. 90% of cases resolve by 2 years. So, if you see a neonatal stridor or stridor in an infant, you will ask the parents that don't worry, we will wait till 2 years of age and try to put the kid in prone position, okay. The cry is typical, we call it crowing, high pitched crowing cry, okay. So, parents are usually very much anxious, but it gets resolved usually, okay. This is respiratory papillomatosis, right? Very difficult thing. Tracheostomy should be used as last resort. MCQ comes where tracheostomy, here the tracheostomy should not be done. If there is, until and unless it's a life-threatening situation, tracheostomy should be avoided. Why? It's a viral problem, right? Viral infection, human papillomavirus 6 and 11, okay. So, it will spread further. So, how will you treat it? First of all, we will debride that area as much as possible, and some medications are there, especially some interferons and bevacizumab. It works wonderfully, okay. And this is the case, laryngopharyngeal reflux mostly comes, the patient's symptoms are some foreign body stuck in my throat, some foreign body sensation, typically middle-aged female, perimenopausal age group with a high level of anxiousness that I might have some carcinoma. Those patients we call it, there is a research paper published by us, we used to call it parasympathetic patients, right? Those patients have high parasympathetic output in their body. So, one of them is high vagal stimulation and high gastrin and high ultimately gastric acid output. Okay. So these patients are having acid reflux and patients typically lump sensation in their throat. Okay. We also call it faucet, foreign body sensation in throat. Okay. So those patients are having laryngopharyngeal reflux. It's basically a higher version of gastroesophageal reflux disease, GERD. Very, very common. Okay. অনেকে বাড়িতে বলতে শুনবে, হ্যাঁ, elderly womenদের আমার গলায় কিছু আটকে আছে. Mostly the diagnosis is this. Okay. And now coming into some malignant tumors. Most common tumor is squamous cell carcinoma. This is a cut section. Total laryngectomy has been done. What is the risk factor? Smoking. Next is alcohol. History of radiation. Okay, barbar CT scan korano hocche ba Hiroshima Nagasaki te bash kore, whatever. If there is a long-term keratosis and leukoplakia and erythroplakia as well, and if there is GERD, that is laryngopharyngeal LPRD, what I told, and human papillomavirus recurrent infection, these are all significant risk factors for developing throat cancer. Very common. Okay. So how will you treat a throat cancer patient? First, we get a radiological assessment. The staging, radiological staging. What is the T, what is the N, what is the M? Okay. Then we will go for a biopsy and histopathological examination. And ultimately a multidisciplinary team will come into act. Okay. So our job is to get a biopsy as an ENT surgeon. Then if our team meeting decides that these patients will benefit more from surgery, then we will go for total laryngectomy. Then the radiation oncologist will give radiation and the medical oncologist may give chemotherapy. Okay. So that can also be done before we. What is neoadjuvant chemoradiation? What is adjuvant? Neoadjuvant means just before the surgery to shrink the tumor, to downgrade the TNM staging so that our surgery becomes easier. But there is a fallacy to that also. If we downstage the tumor, the surgery will be less. So there is possibility that margins will be positive. Okay. So if the disease is extremely bulky and we are very much sure that this kind of cancer will get benefited from neoadjuvant, then only we will go for neoadjuvant. And what is adjuvant? Just after the surgery. Okay. After the surgery is adjuvant, neoadjuvant is before the surgery. Okay. As simple as that. So mostly we do total laryngectomy. So total laryngectomy, so wonderful surgery. We love it. But there is a problem with that. What is the problem? Patient will lose his voice forever. Okay. One of the important function of larynx is speech production, voice production rather. Okay. Speech is a big thing. Okay. So voice production. So the patient will lose voice. And to overcome that, we also have developed many technological things. We can do many rehabilitations. But mostly the first thing is the patient will lose the voice. Okay. So this is one of the case where after the surgery, another thing, after the surgery, what will happen? Where from the patient will breathe in and breathe out. Because larynx is out. So there is no conduit to the lower airway. Nose, mouth is there, but intermediary there is nothing. So how will the patient will breathe? How? We'll do a permanent tracheostomy. The part of the trachea we will take it out and we will suture it, making a permanent stoma. So patient will do everything from here, right? But after the surgery, this stoma can get sometimes recurrent. So what will he do? We have nothing left, right? Okay. So there is also a classification, it's a postgraduate thing, but mostly many complications can happen because in the surgery sometimes we have to create a new pharynx as well. Okay. Because larynx and pharynx has a common wall, right? So that common wall, we resect it out and we build a new pharynx. So there is every chance that this pharynx, that healing is not proper. So whatever you eat, this can come out in the neck. We call it pharyngocutaneous fistula. It's a dreaded complication. Okay. So these are postgraduate thing, but just to have an idea that many things can happen. So with chemotherapy, radiotherapy, sometimes we do revision surgery and some flap reconstruction. This is a complex thing. If you are interested, I can tell you. But the bottom line is, the take home message is, do not smoke. Okay. Otherwise, you can have this condition. Right? Okay. Pharyngeal pouch, very favorite thing in the exam. We call it Killian's triangle, dehiscence in the Killian's triangle. The inferior constrictor has two parts, thyropharyngeus in above and cricopharyngeus in, okay. In between there is a potential weak space, weak area. That is Killian's triangle, right? So there is a pouch formation. Okay? So যে বেশি দুর্বল হয় যেখানে তাকে লোকে গিয়ে লাথি মারে, তাই তো? Same thing, same philosophy. So there is a pouch formation. So food will, the patient, actually the food pipe, it has, there is two food pipe. One is blind, one is continuous, right? So food to ar janbe na, foods do not have brain. Okay? So food will get accumulated here. So and after sometimes it will come out with vomiting, right? The first presentation, first symptom is what? Now, halitosis, right? I know one patient, they came to me, they were boyfriend, girlfriends, okay? They got broken up because of this thing. Early morning halitosis, okay? So bad smell, there is undigested food particle. Anything you want to ask? Okay. So, next there will be dysphagia, right? So 98% patients will have dysphagia, but the first symptoms is halitosis, right? First symptom. Okay. Then undigested food will regurgitate, and obviously this can get aspirate sometimes. There will be continuous coughing, right? And this is typical. We call it borbigmy in the neck. Okay, if you palpate, if you push the neck, there is some gurgling sound. What is it known as? The sign is known as something. It's a name, Bryce sign or something. You just check it out. Okay, I forward it. Okay, so how will you manage it? How will you manage it? We need to what? We need to exercise out this thing, this pouch. Okay. Or sometimes the partition wall. There is a partition wall. We just exercise the partition wall to make it a common tunnel. Right. So we can do it endoscopically. And before that, there are some investigations. One of it is endoscopic examination with flexible endoscopic examination and sometimes rigid endoscopic examination as well. Okay. So name of the surgery, what is the name of the surgery? One is endoscopic diverticulectomy or stapling, right? In that case, we just staple the sac. And another thing is diverticulopexy. We cut it out the intermediary wall, okay? Right. This is another thing, thyroglossal duct cyst. Any idea? Development of tongue, development of thyroid, you know. Thyroid is developed from what? It's not pouch. Thyroid is an endocrine organ. It descends from the foramen cecum, thyroid, right? Descend down in the neck. And that tract, sometimes it persists as a tract. And where in there, we sometimes this kind of duct, fistula, these things can happen. Okay. Typical area is just below your mentum. Okay. Around your hyoid bone, there is a swelling that moves up and down with deglutition and with protrusion of your tongue. right? This is the typical history, typical examination, okay? Thyroid swelling, it moves up and down with your deglutition, but does not move with protrusion of tongue. But here, it moves, right? How will you treat it? How will you treat it? We have to resect the whole tract, right? And the tract hides, it can hide just behind your hyoid bone, right? So, from the base of tongue, from where the thyroid originates, from the foramen cecum area to your thyroid area, the whole tract should be resected along with the mid portion of your hyoid bone, so that there is no chance of anything left over. Okay, in 1921, this procedure has been described by Professor Sistrunk. Okay, so we call it Sistrunk operation, right? So this is a famous MCQ question. So nasopharyngeal tumor, I have already told you, Epstein-Barr virus is one of the important pathological factor. Okay, parotid gland, one of the major salivary glands. Okay, so why the parotid gland is always interesting? Why? Salivary gland, but why it's so interesting? Two things are there, that's why parotid surgery is one of the most difficult surgeries. What? No. Superficial and deep lobe. Yeah. How it is being divided? It's not a true division actually. It's a single gland. It has two parts. We call it two lobes. Okay. So it is arbitrarily being divided with the facial nerve, right? That is not my question. My question is why facial, parotid gland is an area of interest by many surgeons, right? Number one, it's diversity of pathology. It can have many things, right? Many kind of tumor, many kind of pathologies it can have, okay? Probably one of the very few organs of our body where these diverse pathologies can happen, starting from the tumor to chronic conditions, many things can happen, okay? Second is the surgery itself is very interesting because of the presence of facial nerve, right? And it's not a single nerve there, right? The facial nerve gets its all branches here into the substance of parotid. So we have to be very careful during the surgery to preserve all these structures. Otherwise, patients will have extreme functional problems. Okay. What is the name of the parotid duct? Anybody? Name of the parotid duct? Stenson's duct. Very good. And submandibular? Wharton's duct. Right. So you know this is the parotid gland here. Okay. And these are the branches supplying the different muscles. Right. So if I start talking about the facial nerve, then the whole day will go. Anyway, just remember parotid gland has many different pathologies and facial nerve makes it more interesting. So submandibular gland is another salivary gland, most prone to get stones, right? Why? Anti-gravity flow, longer duct, right? And the kind of secretion, right? Okay. So this is Wharton's duct, opening of Wharton's duct, and name few nerves in relation to the submandibular gland. Submandibular is also very interesting. Okay, there are many nerves in and around. One of the nerve is lingual nerve, another is hypoglossal nerve, another is some branches of facial nerve as well. Okay, all can get injured. Okay, so this is the relation. This is the deep part of the submandibular gland. Here is the duct. This is the submandibular ganglion and lingual nerve. Okay. So next day I will ask about the parasympathetic ganglions in head and neck region. Okay. And this is the hypoglossal nerve. What is the function of hypoglossal nerve? Supplies. Which type of nerve it is? Motor, mixed, sensory, what? What? Motor. Hypoglossal is pure motor nerve, right? So which side it supplies? Same side or opposite? Come on, it's a common sense. Same side. It's a motor nerve, na? Efferent nerve. So this I will ask next day. Two important paraganglionic, this thing, parasympathetic ganglion, submandibular and parotid, how it's get innervated. Okay, how is the parasympathetic supply? সবাই শুনলি কথাটা, next day I will ask. This is a common question. কেন স্লাইডটা দেওয়া হলো? Because of this rich nerve supply of the head and neck region. If you visit this slide again and again, you will get anatomy more clear. So trigeminal nerve, because of the trigeminal nerve, the otalgia, ear has a supply from the trigeminal nerve, right? So other structures also having supply from the trigeminal nerve. So dental pain from trigeminal nerve, oral cavity lesion from trigeminal nerve, TM joint disorder, trigeminal nerve. So ninth nerve from oropharynx, tonsillitis will have a ear pain as well. Okay. Base of tongue, glossopharyngeal, stylalgia is glossopharyngeal, right? Stand nerve as well. This is a very important slide. Only this slide, if you correctly read this slide, you can get many important information, right? So refertotalgia, everybody knows about refertotalgia. This question will be asked. Okay? Moms, I am not interested. Just this is a viral infection of your salivary gland. Okay? So how will you treat mums? Microbiology, medicine, pediatrics, pathology. How do you treat mums? But unfortunately these patients come to us. We are not interested in these patients. This is not tumor, right? This is not cancer. This is no stone. This is nothing. Just a viral infection. So how will you treat it? Vaccination দিয়ে কি হবে একবার মামস হয়ে গেলে? Vaccination is prophylactic, right? Antibiotic, why? It's a viral infection. Why antibiotic? No? Which antiviral works in viral diseases? Antivirals are useless until and unless it's a very complicated thing. Okay? Just supportive treatment, right? And look for any complications. What are the most important, what are important complications of mumps? In long range, long duration. One is orchitis, euphoritis, pancreatitis, salpingitis, I don't know. Euphoritis is there, okay. And so mom's patient, male patient, always palpate the testis, right? Okay. But jhampiye pode na. You explain the parents first, okay. And very important, meningitis can also be there, right? Sometimes. So supportive. What do you mean by supportive? What kind of virus it is? Paramyxo, right? What is supportive? What symptomatic treatment? Antibiotic is not symptom. Why antibiotic? What antibiotic? Paracetamol. Okay. Anything else? Call it acetaminophen, right? Paracetamol is a brand name. Acetaminophen. Okay. Next. Ibuprofen. Why? Okay. In case of more pain, okay, moderate pain, you can give it, okay. But NSAIDs are not the first thing, okay. If it is well managed with paracetamol, then paracetamol is okay. NSAIDs can damage more, na? If you give it for, if you prescribe for 5 days, parents are giving for 20 days. So his kidney is down, gastritis is there, many things can happen. Paracetamol is a safe drug, at least in Indian populations, okay. And what? Most important thing in any viral disease, supportive doesn't mean only giving paracetamol. Nutrition, how will you give nutrition? What special nutrition you will recommend? Anything else? Any special nutrition? Nothing special. Okay. Usual home food, home vitamin A. What? Okay, you can give, no problem. Green leafy vegetables everywhere. Why? Kids don't like it. Safe. Okay, no problem. Not in particular, but usual the home-based normal diet is advisable. But the most important thing is rehydration. Okay, take plenty of water. That's more important. Acute sialadenitis, silo means what? Salivary gland, silo. Adenitis means inflammation, acute means acute inflammation. So there are many causes. Okay, it can be bacterial, it can be viral as well. Okay, Staph aureus is most common. Okay, sometimes the patient develops abscess as well. So, and it's common when there is a predisposing factor, like the patients are old, having some medical issues, immunosuppressed, diabetic, that means immunosuppressed, and poor dental hygiene, poor oral hygiene. These are the things where this can happen. Okay. And this is also an MCQ. Some medications are there which can reduce the salivary flow. Okay. Mukh shukno shukno lakche Dr. Babu. And on asking, you discover that the patient is taking a beta blocker. Okay. Or some antidepressants, anticholinergic, diuretics, like that. Salolithiasis. Lithia means what happened? Cat in the house. Okay. Okay. Salolithiasis means, lithia means stone. So stone in the salivary gland or salivary duct, we call it salolithiasis. Okay. This is a typical X-ray picture. There is a flow defect. Can you see it? Black spot. White is the dye, right? So there is a defect here. So that means there is a stone there. Some obstruction is there, right?